So I don't see the participant list ticking up anymore. It's on 25 now, so I think it's good time to start. 26 now, actually. We are very lucky to have Sean Kivlehan joining us to present today's brown bag. The topic is, as you see on the screen, Ukraine Trauma Care Training Program. It's the brown bag, which is slightly different from the usual ones. It's going to describe a training program for its public health importance, and I hope everybody will be interested in having a lively discussion on that. Just to introduce Sean, he is an emergency physician at Brigham and Women's Hospital, assistant professor of emergency medicine at Harvard Medical School, and a faculty of the department of GHP itself. He also serves as the director of the Global Emergency Medicine Fellowship at Brigham. What also caught my eye was that he serves as a consultant for WHO, and he was a paramedic before he reached where he is now. So he's actually training people with on a field that he has been himself doing. So that is a great distinction, Sean. So we are very keen to hear from your experience in a country that needs all the help that it can get. So over to you for about 30-35 minutes, and then a discussion and question answer. Sean.
Great. Thank you so much for that introduction. And thank you so much to all of you for joining and for giving me the forum of the Brown Bag Talk today. It's a really exciting to present to you all and a real honor. So thank you. As mentioned, the presentation we should get through in under 30 minutes, and then really hoping to have some time for discussion to hear your thoughts and suggestions on this project, which is ongoing. So what I'm going to talk about is our trauma care training program that we are doing in Ukraine. This is a partnership between Harvard Humanitarian Initiative and International Medical Corps. It all started, well, this acute project started, I should say, Harvard Humanitarian Initiative. We had been doing work in Ukraine for several years, largely around preparedness for chemical, biological, radiation, or nuclear attacks, and then also doing some emergency care training in coordination with WHO. And then when the war escalated to its current state last February, International Medical Corps was doing needs assessments in conjunction with the WHO Health Cluster. And although there are many, many needs, 3 key needs were identified by IMC that led them to reach out to our group at HHI. And those 3 needs were trauma care training, mass casualty management preparedness, and chemical, biologic, radiation, nuclear, and explosive training and preparedness. So they approached us, and we've worked with IMC on several other things in the past. Some may be familiar with the Building a Better Response course, and there's many other smaller projects. So we quickly realized that this would be a good partnership for us, HHI being an academic and subject matter expertise partner, and IMC being the operational logistics partner. And I think that not only outside of the work that we've done, it's also created a good model or reinforced the model for academic NGO partnerships in humanitarian contexts. The needs assessment, we broke it down into several program streams. For the clinical courses, we wanted to make sure that we trained all levels of providers. So we planned for trauma training of physicians, nurses, pre-hospital providers, and civilian bystanders, recognizing that all people in Ukraine were affected by trauma and were becoming first responders by default in this war. So we did a special focus on training civilians, targeting special populations such as public transit workers, people working in the subway systems, which had been converted into shelters, people working in the electrical infrastructure grid and maintenance as they were dealing and continue to deal with many attacks. And I'll talk a little more about that. And then we created the clinical adjacent program streams, mass casualty management course. And this is training facilities how they can quickly switch to provide trauma care to large quantities of people. If you could imagine a typical hospital like the Brigham suddenly having to deal with hundreds of war-wounded patients, they would need to significantly adjust their operations in a very short period of time. So working with the WHO, we have helped hospitals prepare for that and how they can better manage that. CBRN training, the chem, bio, radiation, nuclear explosives training, preparedness, not just for individuals and how to care for patients in the event of an exposure, but also for facilities. How can healthcare facilities prepare for an influx of possibly contaminated patients to prevent spread of contamination to other patients or to the providers themselves? Videos, we also realized quickly that there were some areas that we would not be able to reach for security and logistics reasons, and also just for availability of people who wanted to learn. So we created a long line of asynchronous videos, pulling out key topics from each of these courses, and then training and then using them to push out to mass populations. These are short 2 to 3 minute videos, and I'll show you an example at the end. And finally, we quickly realized that although we had inserted pediatric specific topics into each of these courses, we realized that there was a huge demand for additional pediatric training, as sadly there are many pediatric injured and also suffering from other acute diseases. So we created a new pediatric specific training program as well. So these are the 8 program streams that have been ongoing, and actually for a little over a year now I'm doing this. Our key partnership, although the foundational partnership was between International Medical Corps and Harvard Humanitarian Initiative, we reached out to some other people in our network here locally. And this is one of the amazing things of being in Boston and being at Harvard, is you have at your fingertips just a truly endless network of experts in whatever the topic is. So at Mass General Brigham, which is inclusive of Brigham and Mass General Hospital, we were able to identify many experts in emergency medicine, pediatrics, and trauma surgery, and burn and blast injury as well, and brought them together to help with this project. Boston Children's Hospital has a very large global health program that has been a key partner of ours in many other projects, particularly around the pediatric aspects of care, and they become a foundational partner of this. And GMKA, Global Medical Knowledge Alliance, is a Ukrainian NGO led by 2 surgeons, one based at Brigham and one based at Mass General. And the co-founder, Nelia Melnichuk, who is an oncology surgeon at Brigham, led all of our interpretation and translation efforts for this project with her NGO. So it was a really incredible local effort that we were able to pull on all the resources here. Of course, to do a project like this, then the next step was to build a team. And this is just a small sampling. I'm not going to go through each person here in detail, but just to show you the amount of people that it takes to make something like this happen. And we pulled together this team in less than a week, back at the end of March and early April last year when we were starting this project. And and this is just the core leadership team of all the different lines of work and project streams, because it's not just training courses, logistics, it's travel, it's M&E, it's translation, it's getting classes booked, classrooms, all of these other things that go into it. So it's been an amazing team and a real privilege to work with. Many of these people are affiliated with different programs in the Boston area, and I'm sure some of you have worked with them in the past. And then we had to put this whole team together and create an organogram from the ground up pretty quickly of how we're going to coordinate all these different lines of work and courses and efforts in the cross-programmatic support. And then the next step was deciding what were going to be our intervention regions. So in coordination with International Medical Corps and the WHO Global Health Cluster, and specifically the Ukrainian Health Cluster and the Ukrainian Ministry of Health, we coordinated areas that were a combination of had need, but also accessibility. Because remember, you can't teach a class of healthcare providers if everybody is busy working and taking care of patients. So we had to balance the needs of taking people away from clinical work. We've done this work in different phases. In phase 1, it was taught in Kyiv, Dnipro, Zaporizhia, and Odessa that you can see here. Phase 1 happened in the summer and fall, and then we transitioned to phase 2 in the winter and spring, which is currently ongoing. And we've expanded to other areas, Lviv Street, Bucha, Irpin, and then now actually our team this week is in Izmail right now teaching trauma courses, and they'll be in Odessa next week. And the phase 1 was about training students in these courses. Phase 2 is now training instructors and training local Ukrainian providers who took the classes in phase 1. We're now training them to be instructors to teach their own classes. And then phase 3 is going to be, which will start in the summer, will be training instructor trainers. So the next level, coordinators and partnering with universities, academic centers in Ukraine, the government and medical facilities to create a sustainable infrastructure. This is just to give you an idea of the logistics that it takes to do something like this. for each of these classes in phase one, we needed at least 5 instructors that were already trained. So these are people who took time off from their clinical duties or other academic duties and traveled to Ukraine. You cannot fly into Ukraine. So we would fly into Poland or Moldova, depending on where the classes were. And then you would take a car to the border and then walk across the border on foot to avoid the traffic and excess delays there. And then another car would pick you up on the Ukraine side and drive you to your destination, which, for Kyiv is about an 8-hour drive from the border. And then further on to Dnipro is another several hours. You could, the lead and exit times, just to be in country for a week or two, you would have to add on several days of time. So it was a pretty heavy logistical lift that IMC made possible for us. Then pulling out, here's a typical week. And this is just one block of training. And we've been doing training now where we're about to run out of alphabet letters because we named each one of a different alpha wave, beta wave, etc. And we are currently on Romeo wave right now. So we're getting towards the end of the alphabet, which is great. This is one example. This is a block in Odessa, and you can see the typical work week for our instructors. They would teach, we'd have the ATLS for physicians, the trauma nursing course, and the pre-hospital trauma courses all running concurrently. And these are 2-day courses. So they would be taught Monday and Tuesday. And then the day 3 was training instructors and doing extra optional training topics. And then they would repeat Thursday and Friday and train another course. And then the following week would be the clinical adjacent courses, mass casualty management, CBRN, etc. And then Stop the Bleed is the course that we did for all of the civilians. And we would just add these classes in at the end of days on the weekends. And this is a very brief course to train civilians and bystanders how to do hemorrhage control. So after all that planning, the courses got started. This is in Kyiv, in one of the hotels where we were doing trainings, and it had everything set, and it was very exciting because it was all coming to fruition and it was happening. And you can see our instructors here just teaching. It was a very hands-on, small group, skills heavy after some introductory lectures, and very well received. Classes have been oversubscribed consistently. And then you can see some of our more, as we transition to local instructors, the classes have become even more engaging. But then the reality of this type of training and meeting this need quickly is that there is a war going on. So this is a screenshot of the app that when you're in Ukraine, you download, and it's the Air Raid Siren app. So basically it tells you when there's incoming enemy fire, missiles, things like that. So, and you would get, everybody has this on their phone, and then the phones would all alert. And I just have the Google Translate screenshot on the right, so you can see what it says, and tells you stop everything, go to the shelter. So every hotel, restaurant, anything has shelters now in the basements, usually stairwells, things like that. Or even if you're on the street, public places open up their venues to shelter so people can leave the street quickly and go into any public area to shelter for an incoming attack. So this would, as you can imagine, disrupt class, right? So we would, these would happen several times a day. We would stop class so that people could shelter as needed for safety. And then it got to the point where we had to shift our planning due to security. And we weren't at the front line. We didn't want to take people away from doing that type of work. But even behind the front lines, you can imagine there were still these long range attacks. So, and the security issue really changed how we did things, doing this type of work in a conflict zone. So you can see, like, this picture on the left this is when you landed at Rzeszów Airport in Poland, and just really sets the tone. These are the Patriot missile batteries that NATO has laid out there. So this is the closest that you can land alongside these air defenses, and then you go in from the ground to there. And this is to give you an idea of the situation. So this is a live UA map. So some of you, I'm sure, are familiar with OpenStreetMaps, which is an incredible organization and service, and they do these live maps for many places in the world. And here is Ukraine. I took this screenshot about an hour ago and put it on. So, and anybody can go to this website, just live UA map, type it in, it'll come up. And this shows just attacks in the last 24 hours. And you can see just how active the conflict is right now. And then on the right is a pseudo Twitter feed of the attacks that are happening with links to news stories or videos that are posted on social media. So we would be tracking this all the time, and you can see, sadly, this is just an hour ago. So this is very active. So because of this modifications of the concept of security, we decided to just move our trainings into the shelters because we were losing too much teaching time by going back and forth. So this is one of the ER faculty doctors at Brigham and Women's, Dr. Catalina Gonzalez Marks, teaching with, let's see, one of our translators, teaching mass casualty management in one of the bomb shelters in Zaporizhia a few months ago. And the classes, it was amazing because the demand for the classes and the learning was constant. So the students, we would be over capacity in these shelters of people taking the classes. Courses when it was taught by a non-Ukrainian speaker, an English speaker, we had live in-person translation bi-directionally the whole time, and that's what you can see happening here. And now, as we're in phase 2 and having more local instructors, the translation needs are less and less. We also changed our trainings to reflect the realities that students were facing based on feedback. So this is one of our Seaborn courses, and creating building collapse simulations and working in limited visibility environments. How do you extract patients? How do you do it safely so that you're not injured and you can still care for patients? So we started to try to get as realistic as we could with our scenarios. This is our national staff, who is quite incredible. We've our national staff, which continues to grow. And you can imagine the disruption that happens in a war. It's the first thing you think about is the violence and injuries, of course, and things like that. But it's so much more than that, and so much deeper. Many people imagine if you're a medical resident or a surgical resident in your training, and suddenly your country goes to war and you can't complete residency, or if you're halfway through medical school or halfway through any school. If you're whatever you're doing in your life, everything is upended, and how do you continue that? We were lucky enough to hire many local staff whose lives had been disrupted, and they've been able to provide incredible support to our program and really spread it. And for several of them who are have medical training, this has been an opportunity for them to advance their medical careers, which has been great. And you can see on the bottom left is one of our, we sent over a bunch of Harvard swag, and we joke bowling is one of the things that have been open and that people are doing. You know, I have our Harvard bowling team based in Ukraine there, or our local staff who is still undefeated. To get into some of the data, so the classes that we've taught, you can see phase 1 and phase 2. So 10 courses of each for the core clinical courses that are 2 days each and pretty equipment and instructor heavy. And then, so it's ATLS for physicians, trauma nursing for nurses, pre-hospital trauma, stop the bleed for civilians. It's a shorter course. We teach many more of those courses. Mass casualty management is MCM, is the WHO surge program. CBRN, and then PED. We didn't do PED in phase 1. We started it in phase 2 based on feedback. This is for phase 1, the students that we trained. We trained around 2,100 students in phase 1. Our current tally is we're just over 4,000 students right now that we've trained, and this is all in-person training directly by us, and it does not include the scaling that has happened, because everywhere that we go and teach, we bring an entire complement of equipment to teach that class, and then we leave it behind and donate it to a local academic or healthcare institution, and they continue the training without us, and we just support remotely as best as we can. So the program is growing exponentially, and it's growing so fast we're having a hard time tracking the numbers, to be honest, as we try to see the amount of trainings that are happening throughout the country. But it's really amazing to see as these numbers grow. Every course that's done, we measure effectiveness through a pre and post test, both objective knowledge assessment tests, written tests on multiple choice exams, and then also confidence surveys and post-course surveys and skills assessments. You can see here, this is just a summary for our phase 1 of the program. Every single metric that we used, every knowledge assessment, pre-post test, everything improved in this, and it was statistically significant in every single aspect. So it really has been effective at transferring knowledge, and we've been doing follow-up surveys at 3 and 6 months to assess retention of knowledge. And the amazing thing is the use of the knowledge, and we ask students if they have used the knowledge that they learned in the class or the skills, and overwhelming majority have used the skills within 8 weeks of taking the class. Some anecdotes are of people describing that their apartment building or an apartment building on their block was bombed, and they felt empowered to go help people and stop bleeding and support their neighbors. And so these are non-healthcare providers, and then of course healthcare providers have similar stories of treating patients in healthcare facilities. It's really been it's been an odd combination of inspiring and really saddening to read the comments and the feedback that come in of just how real this is, and unfortunately how needed it is. The dashboard that we maintain, just to give you a little more granularity of every course that we're tracking, all of our different metrics. Again, just trying to identify problems so we can correct them. Most of the time I have to do a data entry, but we also, as you can imagine, a project of this scope, there's major data entry. We use Kobo on the back end to collect all the data, which is a great tool. And it's tough across language barriers, across Wi-Fi connections, and just the scope of the project and the interruptions due to attacks and things when we need to shelter. So this is just some summative course evaluations that we have of people that do after, and you can see fairly positive. People thought it was relevant, customized to their setting. They felt confident, they'd like more training, and then we have much more granularity of these that I'm not going to bore you with. We've also had many spin-offs of this project. So this is just one example with the Swiss Foundation and the Project ECHO, that is an incredible program that's out of University of New Mexico, and it's kind of a twist on telehealth, doing remote education. They do a lot of this first in the U.S. around the Indian Health Services programming, but then it has really scaled to many other settings, particularly in the global context. So we partnered with them and the Ministry of Health to create a training series where the trainings that we were doing, and we started leading these online courses as well. You can see this is just one of the ads on the right for it that was done, and this has been a great way to continue to reach people and also to support people that we've trained so they continue to feel empowered. The videos I mentioned at the beginning, so we created a line of work creating these short asynchronous videos. We made 26 of them in all. And this is just us filming them. We partnered with the Stratus Center at Brigham in Longwood. For those of you that know, it's a simulation center for Brigham and Women's Hospital. They were really generous with their time, and had a production company called Element, who normally does commercial production, video production, and they worked really closely with us to create these fairly high quality videos, which have been great. This is Michelle Nishrenko from Boston Children's Hospital, and Josh Drake, who's a medical student, who doing one of our pediatric trauma videos right here. These videos, we posted them on YouTube, and it created a whole library. They're in Ukrainian, and we have Ukrainian narrators. And not only that, they've been designed to scale beyond just Ukraine. So I'm going to show you quickly the introductory video right now to the series. It's just over a minute long. So I'm going to I'm going to reshare my screen to the internet here, and then we're going to hope that you can hear the sound on this. So, and somebody can please let me know. I'm going to start playing this right now, and let me know if you can hear the sound or if you can't. Can you hear it?
No.
You can't hear it?
No.
Okay, let me try to change this to do name as system. You need to share audio. Somebody's telling me, oh, here it is. Okay, one moment, we're going to be there. Thank you, Sabrina. Okay, I knew there was a way. All right, here we go. Let me know. Somebody give me a thumbs up if you
Watch
can hear
these
it.
videos and save a life. During this time, everyone must be ready to be a first responder. This video series guides you through the most common crisis scenarios and provides you and empowers you with the information you need to save a life. These videos can be used in real time or reviewed before use. We develop these videos for you and public safety professionals like medics, firefighters, hospital workers, and law enforcement officers. This video series has been designed by experts in medicine, public health, education, and communications. This gives people the best open access, trusted, ready to use information in an open access format. Watch these videos and save a life.
Sean, you are mute.
Thank you. So that's the promo video. That's in English, obviously, because it's targeting English speakers. But all of the other videos, you can see it, and the actual training videos are all in Ukrainian, and there's a dubbed version of that that's also in Ukrainian. So this got the attention of the Clinton Global Initiative, and the video work that we've done just got picked up by the Clinton Global Initiative, and you see Eric, who created the videos here, and he's our lead on that line of the work, meeting with Bill Clinton after they decided that they named us to be one of their commitments to action. So it's been a great partnership, and we're partnering with Ariadne Labs and other organizations to scale these videos beyond Ukraine. So they were all designed in a way where they can be quickly dubbed into any language, and we are now going to be using them to try to really release and as Eric would say, democratize medical knowledge to people around the world in these very short 3-minute key videos that we hope can be used both as just-in-time training and also as reminders. And that's it. That's where we are. So this is, just a picture from just downtown Kyiv in the government center here, and it's just just been an incredible, amazing, and humbling experience for me over the past little over a year now, working on this project with just a truly inspiring team of people, both in the U.S. and Boston area, and also in more importantly in Ukraine, and just an incredible partnership of local staff, institutions, NGOs, UN organizations. We've gotten the support of so many medical organizations and UN organizations and NGOs for this work. Other NGOs have been sending their staff to our classes. It's really been great. And it's just so sad to see, just the situation. We have enough, natural disasters in this world, and that we have these man-made disasters is what breaks my heart the most. But it's empowering, I think, to everybody that we can try to do something about it to improve outcomes. And if you have more questions, my email's down there, but I think I'll wrap up and we have some time for questions. So thank you so much for your time and attention.
Thank you so much, Sean. My internet failed in between, so I was kicked out for a little while, but thank you for presenting this. And of course, we have actually quite a bit of time for discussion and question answers. So I will invite any of the participants to raise their hands electronically. I'll try to see who has raised hand and pass it on to you, Sean, for answering it. But before people get ready, I have a question, and I know that I had seen your PowerPoint earlier, so even if I missed the actual presentation, I know what you presented. So this kind of training obviously is very important for public health, and you did present some information on the process evaluation. But is there anything that you have either done or would plan to do for the impact evaluation? The trainings are doing well, but does it actually improve the care for people with trauma? And if you haven't done, how would you plan to do that?
This is the ultimate goal, to get to the patient-centered outcomes and what is the actual impact. Because, yeah, these are process measures. It's one thing to measure pre, post-test evaluations, surveys, things like that. But what we really want to know is exactly what you said. Does this improve the outcome of patients, of the actual patient? It's hard to track because it requires people to be tracking patients and outcomes in the hospitals. And that's what we're really hoping to get, though, and working with IMC and WHO to see if there's a way. One thing that we're sketching out right now is there a randomized type component to this where we could train all the staff in one emergency unit or in one region of a hospital and not another and look at outcomes. It's tough because you don't want to be somewhere and not offer training. You want to make sure that if you're collecting data, that it's a bi-directional, that we're not just taking data on a control group, but that we're actually training people everywhere we go. So we're trying to sort out, and I'm open to suggestions because it's really been the biggest challenge, and it's the biggest unanswered question for me and for everybody else. Not just with this program. Before this, we've done a lot of work with WHO and ICRC on the basic emergency care course, which is a short training course, and it's a similar thing. Looking at the end of the day, we can show the improvement of knowledge, and follow-up and retention of knowledge, but to measure the true impact on patients has been an ongoing challenge. And it's an expensive challenge, is part of the problem too.
Thank you, Sean. I would encourage any of the participants to not only ask questions, but if they have any suggestions or comments, feel free to chime in. Either raise your hands or you can just unmute yourself and say something. And I see Dan's hand. So Dan, over to you.
Hi. First of all, this is just a wonderful thing. It's inspiring to hear, and proud to be associated with you. In my limited experience in Ukraine before the war, corruption was so prevalent that it extended even to things like getting a DHL parcel delivered to its intended target. People said, "Don't bother; it'll be diverted." I don't know if you feel comfortable talking about this, but if you are, could you say whether or not the widely noted corruption in Ukraine has been a problem for you in this project?
Great question, and it's a real concern. I mean, corruption and graft, and it's not limited to Ukraine, but definitely was a concern before the war in general. And I think anytime there's war or conflict, it opens up opportunities for worsening graft and corruption or new forms of it. We haven't dealt with any issues of it. We're aware of it, and I think it's responsible to be aware of it as stewards of money and resources and personnel to make sure that things are being done as intended and money is being spent as intended. And so far we have not had any issues. We've been able to track all of our equipment and where it goes. I think this is such a niche project with the healthcare system that people are just so engaged, and we're partnering so closely with healthcare providers that when we hand over equipment, we know exactly who we're handing it over to. However, I do think that when we scale further, I mean, we're scaling now, but we still are only just beginning to scale. And as we do further, I think it's going to become a concern that we're trying to put plans in place of reporting mechanisms and feedback mechanisms. But yeah, it's a concern, and with all projects, but I think so far we've managed to avoid it by the direct control.
Thank you, Sean. I have another question. We have many stakeholders that you talked about, and I'm particularly keen to hear your further views about what kind of support and cooperation you got from the government of Ukraine itself, but also the local government, and also from the professionals, the local professionals. And were there any barriers, or everything was just going very well, or what did you do to obtain that kind of support and collaboration from the local people?
Yeah, it's an ongoing process. I mean, the first question is, do people want this, right? So just because I think here in Boston that this trauma training might be a good idea for people in Ukraine doesn't necessarily mean that it's a good idea or needed or wanted. So the first step was that needs assessment and understanding what are the needs, and that was collated by the health cluster, WHO, which works directly with government and other organizations locally and globally. But then as we really started to say, okay, here's the general ask, how do we whittle it down? It was literally knocking on doors and going to hospitals and saying, what are the needs? What do you want? And making sure that this would fit. And a lot of places it didn't fit for a variety of reasons. So, and we would find other places where the training would be most useful. The partnership aspect is the most important part of this type of work, but probably one of the more challenging. I don't want to say difficult, just challenging, because there's a lot of people and a lot of players, and the people in positions change quickly. So having GMKA, Global Medical Knowledge Alliance, which is Nelly Malachuk and her husband Sergey Malachuk's NGO, they've been critical because they have partnerships and have been working locally for a long time. We leaned on our prior work that we did in Ukraine before the war escalated, and that was in partnership with some healthcare institutions and government officials. And then through IMC's had a presence. I mean, we couldn't do this work without IMC. and they have had a presence in country for a long time and already had a pretty established network, so we're able to build off of that. But it's a constant reevaluation. I'd say I spend, I mean, just this week I've been on meetings with several different universities and stakeholders locally, and realize we are always trying to identify partners, making sure we're supporting people how they want it, when they want it, and constantly adjusting our programming based on that feedback. It's I think just keeping that the guiding light of we're just there to support at people's request and not being imposing. So, and that means being very flexible and changing constantly. But it's probably the most important and probably the biggest, if you think of time blocks that are used in my time, and probably constantly checking with partners is the biggest time commitment.
Thank you, Sean. I am still looking for comments, suggestions, or questions, but I don't see any right now. So I have another question actually, and that is on the cost side of it. In terms of tangible as well as intangible costs, uh, did you have any assessment? And based on that, what would you see as a sustainable model for these kind of costs to be incurred in Ukraine, but also perhaps in other emergencies, which unfortunately might arise in future?
Yeah, great question. So we've been tracking the cost throughout, and this type of programming and similar types of programming that we've done in other places is always very front heavy and expensive on the front end. It involves bringing in instructors, bringing in equipment, and setting up venues. And then when you bring in instructors from that are not local, there's a lot of travel costs associated with that as well. So from the outset, the plan was always to quickly transition to local leadership, as I mean, quickly is a relative term, but to move in that direction. And that was the 3-phased approach. Was the first phase was expat heavy, international instructor heavy. Second phase is training local instructors, and then third phase is fully led by local instructors with just minimal expat support. So that's where we are right now. And we've been and we've seen our costs and our cost per student trained go down significantly as we have more local instructors and more local leadership, and we're projecting that the cost is going to go down even further. The videos have been definitely the most cost-effective mechanism here. The question is, I mean, those videos that I showed have been viewed over 2 million times in Ukraine already, and in over 500 different cities in Ukraine. So they have good reach. They're definitely being watched. Again, the question is, does that translate into meaningful outcomes? And that's future studies that we're actually planning right now and looking at if the videos are effective in improving outcomes. Because if so, that's a huge cost-effective game changer, and especially technology penetration is consistently growing and around the world. So it could be applicable not just to Ukraine but to other areas. The last thing about cost is for long-term sustainability. No matter how low we reduce the cost, at the end of the day, there's going to be constant costs of running any training program. So these are the discussions that we're having right now with different partners, universities, government, and hospitals. Is what's the model? Is it long-term government support? Because donor support won't happen forever. And even multilateral support maybe will happen for a long time, but maybe not forever. Is there a role that eventually these courses are stabilized and people pay a small amount of tuition to cover costs? So there's different models to think of what is the true long-term sustainability, and that's really exactly where we are right now. That's pretty much what we're trying to figure out. So complex answer, a lot of different levels of cost to it, but I think this type of program is expensive in the front end, but we've done a good job of very quickly moving it locally and having less and less non-Ukrainians involved every day, which makes it much more appropriate and affordable.
Thank you. I am still looking for any comments or suggestions. I see many people who have done similar kind of work in the group, so feel free to raise your hands or just speak up. But just continuing with the discussion on your last point, if the cost was an issue, a limitation, out of all the kind of people you are training, professionals as well as non-professionals, what would you feel is is the kind of best return on that investment? Have you or your team thought about that?
Yeah, and we're always thinking, if you have to make adjustments based on budget, funding, things like that. It's personally, I think, and I don't know, I don't want to speak for the whole team, but my opinion is training the civilians and the bystanders. I think that the delta is the greatest. When you take somebody who works, for example, in the subway system, and these subway systems are routinely turned into large scale shelters. So you have hundreds, if not thousands, of people sheltering in these stations, and things happen. Of course, there's the horror of a direct attack that would injure people, but even without that, there's people slip and fall, people have acute medical conditions, all the different things that happen. And empowering people, the local population, to be able to intervene and provide support and feel confident, I think is the most cost-effective thing, because it's not just tangible medical outcomes. It's also, I think there's a real psychological component to this too, of just people feeling that they can contribute. And that's something we've seen in the feedback constantly, that aside from the skills, just the feeling of knowing that I can help if something happens and I know what to do, and I feel like I'm part of the solution is I think something else that's hard to quantify and really been an important outcome. So I would say if we could only do one thing, for me, it would be training civilians. It's the quickest course. We can do it in 1 to 2 hours. We can train large quantities of people. This course, Stop the Bleed, I mean, they've done it here in the US. They do it at Gillette Stadium. They've done large scale training thousands of people at the same time and showing that they can retain knowledge. So I think these are really effective. Yeah, I mean, of course, you need professional providers and you need the back end, specialist care, all of that, but that's a lot more expensive and time consuming. So I think if you could only do one thing, yeah, it's this: get the training to the masses. Basic is, the most lives are saved with basic care.
Thank you, Sean. Related to your remark about the psychological part, and that happens to be actually my area of interest. So, just thinking again about that a little bit. Yes, it can be empowering. People feel better when they can do something. But out of the people you trained, did you get a feeling that there is a psychological component which could be actually negative to overwhelm them or to expose them to the situations that they may be somewhat less prepared for, and feeling in some way, I don't want to use the word, but in some way traumatized by the experience of it?
Yeah, great point. And to be honest, this is something that I think about, not just with this type of work, but doing domestic training of things. You get then, does the person feel pressured that they have to act because they have some knowledge, or if they do act, are they prepared to deal with the aftermath of seeing, of experiencing some, if it's a physical injury or somebody who's in severe distress. So we incorporate the WHO psychological first aid and some key components of that, which is keeping it very basic, very simple, and trying to just acknowledge it and explain to people that there are, these can be intense events, and inserting yourself into it, it's that people will respond to that differently. Some people, it helps them to, and this is all anecdotal and just my own opinion, but some people, I think, feel that by being part of the solution, by helping, that empowers them and helps them deal with it. But others, it creates more stress and then after anguish, especially if there was a bad outcome of the patient despite them helping. Could they have done something differently? And I don't want somebody to be thinking about that, because so it's trying to message it and prepare them for it. But I do think that is a risk. I would say, again, anecdotally, although we are trying to find a way to look at this because it has something that keeps coming up in our surveys, is I think anecdotally people feel the empowerment is greater, and people are, especially in this situation where the trauma is brought to them, no matter what, and they feel like this is at their doorstep, so at least they can be a little prepared for it. But it's a good question, and I don't know the answer, and I'm curious too of the effects of that.
So, Sean, my last question. Many of the people in the room are researchers. Would you feel there is any potential of incorporating at least some research in the training program that you're doing? And if any of the students are interested, they might just come back to you on that.
100%. My door is open. And I mean, as you can see from the team that we've built, this was basically me reaching out to my network, getting introduced to new people, and putting together a team, which is what makes working here so incredible. Just the group of people that we have access to. So yes, we're looking. We've come across so many questions. I mean, the psychological impact is one, and there's so many other questions of outcomes, how we can better measure outcomes, how we can do this work better. Looking at novel methods of education, whether it's video training, asynchronous training, and we want to look at all of that. So I really see it as the sky's the limit, and we're here to collaborate. And yeah, anybody that is interested, please email me. Be happy to talk, hear about your suggestions. Yeah, because this work again is not, although this work has been done in Ukraine, this is not specific to Ukraine, and sadly, and it can be, and honestly, it's not specific to a conflict situation or a war. We've been trying to take this with an eye of how can this be applicable to many other parts of the world, and to provide useful training to providers.
Thank you, Sean. Just again stopping for a few seconds to see if there is any last minute comment or question, but otherwise we give 2 minutes back to you as well as to all others. I don't see any, so thank you so much, Sean, for presenting some very interesting work and answering all the questions. And thank you all participants for being here.
Thank you. It's my pleasure. Thank you so much.